Carpal tunnel syndrome, or CTS, stands as the most common focal neuropathy affecting millions worldwide. It occurs when the median nerve, which runs through the carpal tunnel in the wrist, becomes compressed. This compression leads to symptoms like pain, tingling, numbness, and sometimes weakness in the hand. CTS can significantly impact daily life, making even simple tasks challenging. Early detection is crucial, as timely intervention can prevent long-term damage and improve quality of life. In this video, we'll explore how advancements in diagnostic methods are making it easier to identify CTS, especially in its early stages, and why combining different approaches is key to more accurate diagnosis. Historically, diagnosing carpal tunnel syndrome has relied on a combination of patient history, clinical examination, and electrodiagnostic (EXD) testing. Physicians look for symptoms such as nocturnal hand pain, tingling, and relief with handshaking. Physical tests like the Tinels and Phelan are commonly used, but no single clinical test offers both high sensitivity and specificity. Electrodiagnostic studies which measure nerve conduction help confirm the diagnosis and rule out other conditions. However, even with these methods, up to 15% of CTS cases can be missed, especially in mild or early stages. This limitation has driven the search for more sensitive diagnostic tools. Electrodiagnostic (EXD) testing has been the gold standard for evaluating CTS. This method assesses the physiological function of the median nerve by measuring how quickly electrical signals travel through it. Abnormalities such as slowed conduction or reduced amplitude indicate nerve compression. Laboratories often use their own reference values, and mild cases may only show subtle changes. While EXD is effective, its sensitivity is not perfect. About 10% of patients with CTS may have normal results. This means some cases, particularly those with mild symptoms, can go undetected, highlighting the need for improved diagnostic accuracy. To address the limitations of standard EXD, the Combined Sensory Index (CSI) was developed. The CSI uses a summary score derived from comparing sensory nerve conduction latencies between the median nerve and other nerves in the hand. By analyzing differences in latency across multiple tests, the CSI increases the sensitivity of CTS diagnosis without sacrificing specificity. A CSI score above 1 millisecond is considered positive for CTS. This approach has proven reliable, catching more cases than single-test methods. However, even with CSI, a small percentage of cases may still be missed, especially those with only subtle nerve changes. Recent years, ultrasound US has become a popular tool for assessing carpal tunnel syndrome. Unlike EXD, which evaluates nerve function, ultrasound provides a visual assessment of the nerve structure. The most consistent ultrasound parameter is the cross-sectional area (CSA) of the median nerve at the carpal tunnel inlet. Swelling of the nerve at this site is a strong indicator of CTS. While ultrasound is a sensitive screening tool, it cannot determine the severity of the disease and, as a standalone test, does not outperform EXD. However, it offers valuable anatomical information that complements physiological data from EXD. Recognizing the strengths and limitations of both EXD and ultrasound, researchers proposed a dual approach, the Combined Median Score (CMS). The CMS is calculated by multiplying the CSI from EXD by the CSA from ultrasound of the median nerve at the carpal tunnel inlet. This single numerical score integrates both physiological and anatomical data, increasing the sensitivity of CTS diagnosis. In a study of 100 suspected cases, standard EXD identified 89 positives, CSI found 92, and CMS detected 95. This demonstrates that combining these methods can catch cases that might otherwise be missed, especially those with mild or borderline findings. CMS formula is straightforward yet powerful. It takes the CSI, which summarizes differences in nerve conduction latencies, and multiplies it by the ultrasound-measured CSA of the median nerve. If either value is normal, the CMS remains low. But if both indicate abnormality, the CMS rises above the diagnostic threshold, signaling CTS. This approach is especially useful in borderline or mild cases, where traditional tests may not provide clear answers. By combining structural and functional data, the CMS offers a more comprehensive assessment, helping clinicians make more confident diagnoses and improving patient outcomes. Introduction of the Combined Median Score has had a significant impact on clinical practice. In the reference study, using CMS increased the diagnostic yield for CTS from 89% with standard EXD to 95%. This means more patients, especially those with mild or early-stage CTS, can be accurately identified and treated sooner. Early detection is crucial, as it allows for conservative interventions that may prevent progression and reduce the need for surgery. The CMS is particularly valuable for clinicians facing equivocal cases, providing a clear, objective measure to guide decision-making and improve patient care. Summary: carpal tunnel syndrome remains a common and challenging condition to diagnose, particularly in its mild forms. While electrodiagnostic testing and ultrasound each offer valuable insights, their combination in the form of the Combined Median Score sets a new standard for sensitivity and accuracy. By integrating both anatomical and physiological data into a single score, clinicians can better identify cases that might otherwise be missed. This approach not only improves diagnostic confidence but also enhances patient outcomes by enabling earlier and more targeted interventions. As technology advances, such integrated methods are likely to become the norm in neuromuscular diagnostics.